Good morning to all of you. So I'm Dr. Shashikala, your general pathology teacher again. I'm here with you all. Am I audible? Yes. Uh, Today's topic is about something important. Okay. What do we see here? What is it that is present here? If I show you these areas, what does it remind you of? And this. Okay, recollect what you learnt in anatomy. So these two are parotids, submandibular, then sublingual, right? So what are they? They're the salivary glands. So let's learn about pathology of salivary glands. In particular, I'm talking about two of the tumors that affect the salivary gland and then infection in brief. Yeah. What do you see here? See the salivary gland enlargement, right? What is it that is so typically seen? What is this part of the ear? This is the ear lobule. So here. So these, whenever there is a swelling in the parotid, and to say that this is parotid swelling, this feature becomes very important. So just look at the swelling, and it typically raises the lobule of the ear. And how is the surface? Any comment on the surface? Here it is smooth. I forgot to get my pointer, I'm sorry. And here it is slightly nodular. You can make out that. But the surface is smooth. See? Here, the swelling is being held. So if we can hold it and move it, what does it mean to you? That means it is not fixed to the underlying tissues. Something good, right? If it is benign, you know what is benign, malignant. If it is benign, it does not get attached to the surrounding tissues. See again, where is the swelling? It is in the left parotid region, and this has typically raised the lobule of the lobe of the ear. Now, I just showed you three areas. 1, 2, 3 for salivary glands. What are they? They're the major salivary glands. What are minor salivary glands? So plenty of them are there in the oral cavity. Now look at this patient, mouth open, you see a lesion. But where is the lesion? It's a very well circumscribed lesion. Where is it? On the hard palate. So this lesion here is arising from the minor salivary gland. Okay. So what am I going to teach you today? The objectives of today's class being the learner should be able, that is, you're all the learners here, my dear students. So you are going to learn at the end of this session. So maybe I'll talk to you for about 40 minutes or so. So at the end of this session, the learner should be able to classify salivary gland tumors. That is one objective. Then describe the gross and microscopic features. Together, what do we say? Morphology of benign tumors of salivary glands. So what is benign tumor of glandular tissue known as? What do we call a benign tumor that arises from glandular tissue? Adenoma. Okay, tumors, that is adenomas of salivary glands. In particular, there are so many types of adenomas. So you are going to learn about gross and microscopic appearance of pleomorphic adenoma and monomorphic adenoma, that too Warthin tumor. Very interesting because you see these patients. I showed you few pictures of patients having this swelling. You mean to say you have to see them only when they come to you, when they present to you with a swelling, or when they go to us? No. Many of them have this swelling, such tumor, for a very long time because it would not have harmed them in any way. So they allow it to grow. The way it is slowly progressing and present over so many years tells us it is benign, right? Some people may come to the doctor when the swelling suddenly increases in size. Or what is the nerve that is there? Facial nerve, right? So some people may come when this tumor presses on the facial nerve. They may come with facial palsy or pain and all that. Otherwise, some people may come to the doctor with, why? More common in females, for cosmetic purpose. Otherwise, they may not come at all. They may say, yeah, it's been with me since many years, let it be there, it's not troubling at all. Okay? So, salivary gland neoplasms have a diverse histopathology. They're relatively uncommon. So, they just constitute 2% of head and neck tumors. There's so many tumors that occur in the head and the neck. So, if we put together all of them, then the lesions that occur, the tumors that occur in the salivary glands, constitute only 2%, right, of the 100 tumors. And when we look at the salivary glands which are affected by this neoplasm, most common is parotid. So 80% of all the salivary gland tumors occur in the parotid. And when we look at these tumors that occur in the parotid, most of them, 80% are benign. That's a happy news, right? Then submandibular. Say about 15% affect the submandibular. Only 50% here benign. This is a positive sentence, right? If I say only 50% are benign, if I say 50% are malignant, it becomes a negative, right? Negative sentence. So 50% of benign means the rest 50% are malignant. So there is an alert here. Then when we consider this, minor salivary glands, okay, only 5% of the tumors of salivary gland occur in minor salivary gland, but when it occurs in minor salivary gland, I showed you a lesion on the hard palate, right? So when it occurs in the minor salivary gland, we are much more alert because the salivary gland tumors which arise from minor salivary gland, only 40% are benign. That means the chance for malignant tumors to occur in minor salivary gland is more. Have you understood? I just tried to simplify it. Hope it's not complicated, right? Now, classification. Even if you have not read anything, if any classification is asked you as a question in the examination, you can so nicely classify it. You can say tumors are classified as benign, malignant. If you want in between, you can say intermediate, malignant. Then fourth one, you may say tumor-like. That is, if you have not learnt anything about a classification, that is asked you in the exam by chance. No, that's how. But most commonly, we expect you to know the WHO classification, a uniform way of classification, which is known to everybody. So salivary gland neoplasms are also classified as benign and malignant. Yes. So benign, malignant. See, these two categories are so well seen here. Benign, then comes malignant. Okay. What are benign tumors? Which are the benign tumors that occur in the salivary gland? We further classify them as pleomorphic adenoma, monomorphic adenoma. Pleomorphic adenoma remains as such, that's the most common one, 80%. Then comes monomorphic adenoma. Under monomorphic adenoma, there are subcategories. That is, various types of monomorphic adenomas are there. What are they? Warthins tumor. It has got two names, additional names. Papillary cystadenoma lymphomatosum, adenolymphoma. I'll talk about it later. Then oxyphil adenoma, which is also called as oncocytoma. Then other adenomas are bioepithelioma, basal cell adenoma, clear cell adenoma. Okay, first classification we know classification of salivary gland tumors: benign, malignant. Under benign, it is adenoma. Under adenoma is pleomorphic adenoma, monomorphic adenoma. Then under monomorphic adenoma, Warthins tumor, occipital adenoma, myoepithelioma, basal cell adenoma, clear cell adenoma. Then mesenchymal tumors. Recall the histology of salivary gland. The glandular structures, there are ducts, all this. And what is it that holds all this together? That is a connective tissue. That is a mesenchymal tissue. Okay, tumors can arise from mesenchymal tissue. We call it as mesenchymal tumors. They're rare. So connective tissue, what does it have? It has fibrous tissue, it has nerves, and it has blood vessels. So similarly, so even hemangioma, lymphangioma, all these are the tumors that can arise from the mesenchyme. Okay, remember only these. Then comes the second category, malignant. So malignant tumors, mucoepidermoid carcinoma, then malignant mixed tumor, adenoid cystic carcinoma, acinic cell carcinoma, adenocarcinoma, squamous cell carcinoma. Epidermoid carcinoma is squamous. At least remember few of the names, because in practical viva versa, teachers, the examiners might ask you to name malignant salivary gland tumors. It should not be difficult for you at all. So when pleomorphic adenoma is called as mixed tumor, there's something called as malignant mixed tumor. Okay, then mucoepidermoid tumor. Then remember the 3 A's: adenoid cystic carcinoma, acinic cell carcinoma, adenocarcinoma. At least 3. Then squamous cell carcinoma. Okay, is this clear to you? You can just click, you can have the screenshot of this and then go back to recollect what you have heard, what I am teaching you now. Yes. So let us learn about pleomorphic adenoma and Warthin's tumor. So what is an adenoma? This is a repetition. I am repeating. Adenomas are benign tumors that arise from glandular epithelium, salivary gland. It has lot of acini, that is a glandular component. A benign tumor that arises from these glands is called as adenoma. So what did we classify adenomas as? Pleomorphic adenoma, monomorphic adenoma. No. So the first component, let us take a pleomorphic. Why is it called as pleomorphic? Why the other one is called as monomorphic? The term is self-explanatory, right? Pleomorphic because it is pleomorphic. It's got a variegated appearance. Where microscopically, when we are looking at this tumor, it shows different areas, different differentiations under each field. We keep seeing something else. That's why it's called as pleomorphic adenoma. So initially it was called as mixed tumor of parotid gland. So when we were all students, we learned it as mixed tumor of salivary gland. Why? What is mixed? Something is mixed. So what is that mixture? So epithelium and mesenchyme. Remember the first classification? So people thought this is arising from epidermal component and mesenchymal component. That's why they call it as mixed tumor, because of the variegated appearance. So now we call it as pleomorphic adenoma. So where does it occur? This is again a repetition. It can occur anywhere. I'm just telling you about salivary gland. The most common 60% occur in the parotid. Then comes the submandibular, sublingual, and minor salivary gland. So apart from this occurs in several glands in the body. It occurs in the skin also, it occurs in the breast, it occurs in the cervix. But for you, it's only that to remember. And who are the people who are affected? Look at that picture. Can you guess the age of that individual? Elderly. So this affects elderly, women and men. More common in women. But I have showed you, I think, all pictures of men. So 4th to 6th decade, female to male ratio is about 3 to 4:1. So it is 3 times or 4 times common in females than in males. So which are the other tumors that are more common in females? So don't say breast and uterus and cervix and all, because that only females have. Anything you remember? You know, general knowledge, whatever. What is present here in the neck, in front of the neck? Thyroid, right? Even the thyroid gland, lesions and tumors of thyroid, they're more common in females. Yes. So pleomorphic adenoma, I told you initially how patients can live with it for their lifetime also, because it is slow growing, slowly grows. Patients will tell. Kannada you can understand. 15 ವರ್ಷದ ಕೆಳಗೆ ಇಷ್ಟು ಚಿಕ್ಕದಿತ್ತು, ಮತ್ತೆ ಸ್ವಲ್ಪ ಸ್ವಲ್ಪ ದೊಡ್ಡದಾಗ್ತಾ ಇವಾಗ ಇಷ್ಟು ಸೈಜ್ ಆಗಿದೆ. Means since 15 years, the patient had, it started as a very small swelling, then it slowly it was enlarging. So it did not cause any significant problem. So he did not come to the attention of the doctor, or he did not come for the treatment. So it's a painless mass. So in parotid, 90% occur in the superficial lobe and most in the tail of the parotid. So mixed tumor, I already told you why was this called as a mixed tumor. Now, so what does this picture tell you now? Don't say that, oh madam, you showed only pictures of men and now you're showing female. No. The moment you look at it, have this picture registered, you say it's more common in females. Yeah. Remember this histology? Salivary gland. This is the acinus. See, acinus has cuboidal to columnar cells, and the type of cells varies from the salivary gland. Serous, seromucinous, mucinous, right? Yes. And can you make out? There is an outer layer of cell. This is the myoepithelial cell. So epithelial cell, myoepithelial cell. So this is these are the basal cells, which are reserve cells. So this is a duct. Okay, straight duct. So what connects the straight duct and the acinus is the intercalated duct. See, the intercalated duct has epithelium and myoepithelium. So it is these cells, from these cells, that pleomorphic adenoma arises. So I'm just telling you about the histogenesis or origin of pleomorphic adenoma. It arises from cells of intercalated duct. So what are the cells? Epithelium, myoepithelium. Two types of cells are there. Now, under histology, we are seeing this. So these are the intercalated ducts. Okay, the picture, diagrammatic representation was very well made out. The same thing what you saw in the previous. So these are the intercalated. So this is the origin. Pleomorphic adenoma arises from the cells lining the intercalated duct. What are the cells? Epithelial cells and myoepithelial cells. Now, how does it appear grossly? Okay, anybody comes with a swelling, we need to diagnose it first, right? So there are so many diagnostic modalities. Only once you confirm the diagnosis, then you proceed with the surgery, what type and all that. So what is the first investigation that anybody would like to do? So what you would like to do when a patient comes to you? Very simple is, send the patient for FNAC. What does FNAC stand for? Fine needle aspiration cytology. So this could be a short note topic for you. FNAC is a very simple investigation which is done as an outpatient procedure. So we do it as pathologists. We just take a 10 ml syringe with a needle and put that needle inside the lesion, try to aspirate the content, put those contents on a slide, make a smear, stain it with HND, observe the cells. It's an easy way to make a diagnosis. So after we give a diagnosis, later all this. So when do we get to see the specimen? It's only after surgery, after the specimen is removed. So how does it look grossly? So the tumors are, they may be from 2 to 6 centimeters in size. They could be still larger. It all depends. But the common size, I'm telling you. And the surface is smooth. Remember the two patients I showed you? One had a smooth surface, the other had a nodular surface. So it could be smooth or could appear nodular, but on cut section. So this is what you people have excised and sent. It could be an oral surgeon or even a general surgeon. So this is the salivary gland. It's a fresh specimen, so it appears so hemorrhagic. And on cut section, we are seeing something which is different. It's not related to salivary gland. So it is the tumor. And we can very well make out it's a demarcated, well demarcated. That means, so one feature we are seeing grossly, it is well demarcated. That's a feature of benign tumor. So well demarcated. And then this appears solid. The cut section could show cyst also. It could show myxoid areas. It could show chondroid. But here it is gray white and solid. See now another tumor that is excised and sent. So well circumscribed adenoma we are seeing here. And I'm telling you well circumscribed. This might partly have a capsule or partly it need not be there. That's why we say pseudo encapsulated. It appears round, has a grey-white appearance. And if you see, somewhere vague nodules are made out here. So that's why we say multilobulated. This is just about 2.5. They should have kept a scale here. So it is 2.5 centimeters. So sometimes the cut section is bluish. That is when cartilage is there. Or it can have variegated appearance, but semi-translucent also. Okay. Does this differ from the previous two cut sections that you saw? Yes. So here, look at the translucent central zone. Slightly bluish, right? It's a myxoid stroma or even chondroid that has a typical appearance like this. Then here, compare with the previous two diagrams, this is the nodularity. See, multiple nodules are there. It is not just a single well circumscribed lesion as we saw in the previous specimen. So multiple nodules are there. So nodularity. Now, so after seeing this, what do we do? So we take thin cut sections of that. With a knife we cut it and then make them into small bits of 2 into 2 centimeters and we process it. We make paraffin blocks to make the slides. So slides are made. We show you the slides in practical class. Yes. But microscopically now we should be able to identify what are all the structures that are there that help us to make a diagnosis of pleomorphic adenoma. So what do we see? We see mixture of epithelial, myoepithelial and stromal component. So when I say epithelial and myoepithelial, do you remember the duct I showed you? The epithelial lining and outer myoepithelium. So all these cells would have proliferated and they don't form the normal architecture. What we see normally in salivary gland. Here you can see them arranged in the form of nest. I'll tell you what is nest. Sheet, ducts, what you saw, ducts. Then trabeculae, yes. Then stroma shows myxoid, chondroid, fibroid and osteoid differentiation. And there is no true capsule, that's why, though it is looking well circumscribed grossly, this tumor can happily enter into the surrounding tissue. See how you peep into somebody else's paper, right? So your vision peeps there. So like that is in the exam. Okay, so that's how this can happily put pseudopodia into the surrounding tissues. Yes. So, important feature remember here, microscopically it is characterized pleomorphic or mixed appearance. What is this mixed appearance? It's got epithelial elements and myxoid elements or mesenchymal elements. So what are mesenchymal elements? It has got a matrix of mucoid, myxoid and chondroid tissue. So two components, I am repeating. So epithelial component, remember epithelial component. So how is it present? The epithelium and myoepithelium I showed you happily proliferates. It forms thousands and lakhs and millions of cells. And there are so many cells that are formed. How are they arranged? They get arranged in their own way. They may be in groups, they may be in sheets, some people like, when you go to a temple or a church or whatever, you leave your chappals outside, right? So if there's a system, then everybody will leave them accordingly. Otherwise, everywhere you can see, somewhere you can see clusters, somewhere you can see sheets, somewhere real, very nicely organized. So that becomes a duct, this becomes a nest, that becomes a sheet. Because why this happens? Why does this not happen at home when only 3 or 4 people are there? Less number of people, they know how it is organized. But a lot of relatives or your friends, many of your friends come home, all the footwear, you can see haphazardly. Same thing happens here in the tumor, and the cells, when they proliferate too much, they're arranged in whatever way they want. If they are following the norms or rules, they're arranged as ducts, acini, tubules. Otherwise, they're in sheets and strands, everything. And how are these cells to look at? But the cells to look at are cuboidal, columnar, just like the acinar cells only. Then myoepithelial cells. I showed you the peripheral cells, which were spindle. So here myoepithelial cells may be polygonal or spindle shaped. So they may resemble the smooth muscle cells. So the material found in when these cells are arranged in the form of ducts, what do ducts contain? Secretion, right? So even here, the secretion may be present. And if we do a special stain, PAS, that becomes magenta colored. And focal areas, squamous metaplasia could be there. And if we want to say morphology is so clear, it's very easy for us to make a diagnosis of pleomorphic adenoma. Or if somebody insists that a cytochemistry, histochemistry has to be done, then all these are the markers: cytokeratin, epithelial membrane antigen, and then CEA. As well as myoepithelial markers are, it is like something like a smooth muscle, because why myoepithelial cells are there in the duct? So they help the duct to contract, expel the secretion. So that has markers of smooth muscle, like actin, we mentioned, S100 antibodies. Now, okay. Repetition, what do we see microscopically? Epithelial component, stromal component. The epithelial component, how are they arranged? And then stromal component is attributed to myoepithelial cells. So chondroid, osseous, hypocellular, cartilage or chondroid-like areas. I'll show you all this now. So we'll start. Now you had a theoretical knowledge of what is present in what do we see microscopically, but I'm showing you all this now. So this is the epithelial component. This is the normal salivary gland. So what is in between the epithelium? This is the mesenchyme. So mixed tumor, pleomorphic appearance. So how are the cells arranged? So here you can see the cells are arranged in the form of ducts. Why do we say this is duct? It is double layered. So here they are arranged in the form of acini, only single layered. Here they are in sheets. Here they are in strands. Cord also you can say 2 layers. See, this is single layer. And what do they contain inside? This is a secretion I was telling you. It is PAS positive. So we can call this arrangement also as a tubule, acini and all that. Here, this is looking like cartilage. Remember the cartilage morphology microscopy that you have learned? Eosinophilic matrix, there are spaces within and cells sitting inside. So this something looks like that. So we call it a pseudocartilage. It's not a true cartilage. It looks like cartilage. So we call it a pseudocartilage. So this is the microscopic appearance, a diagrammatic. Now you have to appreciate that microscopically. So all these pink structures or epithelial components. So here you can make out arranged in the form of, you can say here acinas because single layer. This is the duct, it is double layer. Secretions inside and all these hypocellular areas. See the cells are so much here they are less. And it is pinkish to bluish and there are interspersed cells. These are the myoepithelial cells. So you can call this as myxoid matrix, This is somewhat resembling cartilage, so we call it as chondroid. Lot of pictures I'm going to show you. Okay, so this is the chondroid area. We call it as cartilage only when we see this lacuna and then the cell within. See, this is so well circumscribed. Okay, so this looks like a capsule, but this may not be really, fibrocollagenous tissue. This tumor can go inside. That is what the pseudopodia I was telling. So hypocellular areas, hypercellular. This is the epithelial component. That is the mesenchymal component. Now, pseudocartilage, I told you what is pseudocartilage. Sometimes even cartilage, bone, everything could be there. This is such a nice picture. This is the capsule, but it's not well formed. Okay, so that's why we say it's encapsulated. So this is a duct. You cannot deny it. Can you make out 2 rows of cells lining and eosinophilic secretion? This is an acinus or you can say tubule. All these are epithelial proliferation. See, so nicely the epithelium has proliferated. These are cyst-like structures. The ducts are dilated. They have eosinophilic structure. Eosinophilic material, that's the secretion. So these are the, you can say hyalinized area if it is more pink. This looks more like hyalinized area. So these are loosely arranged cells, loosely cellular zones with the cells which are interspersed are all the myoepithelial cells. So this is a typical morphology of, microscopic morphology of pleomorphic adenoma. So microscopically when we look at one field we may see only this. Then another field we may see this. In another field we may see. That's why we say pleomorphic. Not just one field has all these features. So this is somewhat looking like cartilage, chondromyxoid. When it is bluish, we call it as myxoid. All these are the epithelial components. Now you know how they are arranged. See, all highly cellular, arranged in the form of ducts and acini and loose textured stroma. See again. So the myxoid stroma, so well made out. These are the myoepithelial cells. Some of the myoepithelial cells are very nicely seen as spindle-shaped cells. So these are myoepithelial cells. So the myxoid stroma, this is loosely cellular stroma and the normal salivary gland there. That's a parotid. You can see the duct-like arrangement and the myxoid stroma. All these spindle-shaped cells are the myoepithelial cells. So a lot of pictures I've put here for you to identify. Now I will not identify any of the structures here. So you should tell me what is what. Okay, identification is left to you. See the secretions, see the acini, see the sheets. This also can be called as a sheet. The loose, those myxoid stroma and the myoepithelial cells. There the cells are more epithelial and the myoepithelial component. See, very nice myxoid stroma. This is the one which gives rise to that translucent appearance grossly. See, look at the myxoid stroma and look at the epithelium arranged in the form of ducts. Yes, this is just a repetition. So now I told you most common is parotid, then comes submandibular, then sublingual and the minor salivary gland. So what is the prognosis? Clinical features now we know it's slowly growing. So what do you tell the patient after surgery? Do you tell him that it's totally benign and you may go back? Yes, but still remember there is a chance of recurrence. Okay, so recurrence rate. Why recurrence? The tumor you remove and then tell them that it's benign tumor pleomorphic adenoma, he comes back. And if You do not communicate properly. Communication is the best skill all of us should have. Okay, if you do not communicate with him properly and tell him the nature of the tumor, and if it just recurs, then he will sue you in the court. So you can tell him, because though it is capsulated, though it is benign, sometimes this capsule is a pseudo capsule. If you have not enucleated properly, or in spite of removing the tumor extensively, there's always a danger of touching the or damaging the facial nerve. We should be very careful. So if there is spillage during surgery, some amount of tumor is spread there, so they can come with recurrence. Okay, so you should educate the patient about this. It's slow growing, but notorious only because it recurs. And sometimes, I told you why they come to the doctor, though the tumor was present for a long time, sudden increase in size or change. That might indicate that this tumor is becoming malignant. Rare. So risk is 2% if present for 5 years, or 10% with 15 years. Then there may be squamous cell carcinoma arising or adenocarcinoma. So that has to be known about the prognosis. So recurrence, I told you why recurrence, incomplete surgical excision or pseudopods which are going, or then spillage during surgery. So complete surgical excision is what is important. Yeah. So this tells us only about salient features of important malignant tumors. So I'm not dealing with malignant tumors. Maybe you learn it in oral pathology. But for you now, it's important to know about adenomas, and according to your syllabus, it's only adenomas, and pleomorphic adenoma and Warthin's tumor. Yes. That's about pleomorphic adenoma. Is this concept clear? So you may just give me a call if there is any doubt on my mobile number, 9972509785. So just WhatsApp me if you have not understood, or if you have any queries regarding your learning or reading or whatever. I'm there always to help you. Shall I proceed with monomorphic adenoma? Remember the monomorphic adenomas, what were all the tumors I told you? Warthin's tumor, occipital adenoma, myoepithelioma, basal cell adenoma. At least 4, remember. Yes. So monomorphic adenomas are benign epithelial tumors of salivary gland. Here, what is lacking? Why do we call that as pleomorphic? Because there were mesenchymal elements there. So here, no mesenchymal elements. So we are learning about Warthin's tumor. Don't you think this name is so vague, and why did the name come? Yes, Warthin was a pathologist who described this two cases in 1929. So he was observing these salivary tumors, and he said these two tumors, some of these tumors, at least 2, look totally different. So that's why it was not pleomorphic adenoma, it was different. And in what way it was different, and what did it show? It had peculiar microscopic features. So later they called it as, because Warthin discovered it, described it, they called it as Warthin's tumor. It just goes by the name of the pathologist. So it has got other names. Just remember the name. Name is so self-explanatory. It's called as papillary cystadenoma lymphomatosum, and it's also called as adenolymphoma. So if you just look at this name, it's a descriptive name, papillary, because there are papillary projections in the tumor. Cystadenoma, it's an adenoma, it's a benign tumor because it's got proliferated glandular tissue. Cystadenoma, because it has got cystic spaces. Then lymphomatosum, it's got lymphoid tissue. So because it has all these the microscopic features or different types of tissues, it is called as papillary cystadenoma lymphomatosum. Adenolymphoma, that means it's got 2 components. Adeno, the glandular component and the epithelial component, and then lymphoma, the lymphoid component. And peculiar features you should remember, it most commonly affects the salivary, very common or most common or sometimes exclusive, it affects the parotid gland. Pleomorphic adenoma, it occurs anywhere, right? So where common site for Warthins is parotid. It could be unilateral, it could be bilateral. That's another feature. Who are the people affected? Elderly individuals. Who? Men more commonly. In general, I told you, salivary gland tumors are common in females, but remember parotid, men and people who smoke, chronic smokers. This is only for you to remember. So it exclusively occurs in parotid, sometimes bilateral, elderly individuals, males, and who are chronic smokers. It grows, it grows as a it's also slowly growing tumor. It has its own lengthy process. And when such patients are sent to us for FNAC, that's another feature. When we examine, we feel, this tumor is cystic, it's not solid, nodular and all that. And if we put a needle, that is the syringe with the needle and aspirate, we get hemorrhagic material, maybe slightly mucoid, but hemorrhagic material. All these features give us a clue or tell us that, oh, you must be dealing with Warthin's tumor. See, clinical features now. Parotid. This is bilateral, right? Elderly male. This is the left side, that is the right. So, unilateral or bilateral. Slow growing painless nodular mass of parotid. And here the lobule is raised. So when we touch it, so the consistency, when we are looking at it, probably we feel, oh, it must be soft and cystic. Right? It's at the angle of the mandible, and then usually about 3 to 4 centimeters. And elderly individuals who are smokers. A benign tumor of the parotid comprises of 8% of all parotid tumors. See, repetition of what I told you. Men, 4 to 7, elderly, most common is parotid. So very rarely it may arise from submandibular. Every rule has an exception. But the histogenesis of pleomorphic adenoma, remember intercalated duct, myoepithelial cells and the ductular epithelial cells. Here it's much more debated. Okay, so they say it arises from the parotid ductal epithelium that is present in lymph nodes which are adjacent to parotid. There are lymph nodes here, right? So some amount of parotid epithelial cells which are there in the lymph node, from there it arises. Maybe a developmental issue. So tumor develops from parotid ductal epithelium present in lymph nodes adjacent to or within the parotid gland. So happy. Why? Because this tumor is composed of lot of lymphoid tissue. See, gross. Mode of diagnosis, same I told you, FNAC. Then give a diagnosis on fine needle aspiration cytology, looking at the cells. The surgeon operates it. So when we look at the operated specimen, cut and see, this is well circumscribed, encapsulated. It's got a smooth surface. There could be cystic spaces within, and they may contain blood or viscous fluid. And solid areas with white, it almost looks like these whitish areas like a lymph node only. Encapsulated oval, there could be cyst-like spaces. So there are two components that we see microscopically: epithelium and lymphoid tissue. So epithelium and lymphoid. For pleomorphic adenoma, we said epithelial component and mesenchymal components, right? So here it is epithelial component and lymphoid tissue. This is the lymphoid tissue. See, the epithelium is so pink in color, right? They all have eosinophilic cytoplasm. How many rows of cells are there? 2 rows, very nicely made out. And what is this? This is a space. What is that space we say in the tumor? Cystic space. And what's happening to these tumors? This is projecting into it. What is the name of this tumor? Papillary cystadenolymphoma. Papillary projections going into the cystic spaces. So this is very nicely seen now. So 2 colors can you make out? Pink and blue. This is the epithelium. Pink color. Blue. What is this blue color? Lymphoid tissue. There's so many lymphocytes are there. They're not inflammatory cells. They're all forming lymphoid follicles. It's just like how it is in the lymph node. See, they've formed a follicle. They're all aggregated together. So 2 components, the epithelium and the lymphoid tissue. The epithelial component typically is bilayered, 2 layers. So it's got eosinophilic cytoplasm and columnar cells which towards the cystic space, and then cuboidal cells towards the lymphoid tissue. I'll show you that. So 2 structures you have to identify along with the cystic spaces. These are. And what is this? That's a papillary projection, finger-like projection. See, that is like a papillary projection. See, papillary projections into the cystic spaces. Epithelium is double layered, columnar here and cuboidal inside. Columnar towards the space. Stroma has lymphoid tissue. See, this is from your textbook. So nice eosinophilics. The cells have such nice eosinophilic granular cytoplasm. We can appreciate that very well. So here they've shown only 1 layer, another layer should have been shown. And this is the lymphoid tissue. Here it's forming lymphoid follicle. Once it forms lymphoid follicle, we may see pale inside area, that is the germinal center also. This is the same picture which you saw previously. So the columnar cells within and then cuboidal cells towards the lymphoid tissue. And maybe I think the pictures which show germinal center, so a lot of cystic spaces. All these are cystic spaces which have got that viscous material, eosinophilic material. Now 2 colors you can make out very well. Pink is epithelium, the rest of it is lymphoid tissue. See, the lining cells are so well made out here. This is the rich lymphoid tissue. That's why they said, where did it arise from? Probably the epithelial component has got stuck in the lymph node from where. So this is the germinal center of the lymphoid follicle and 2 rows of cells. This is columnar and this is cuboidal. Double layered cells are very typical. We'll show you these slides also. Very easy for you to recognize. So easy for you to remember. Is an acronym here, WALE. W stands for Warthin. So Warthins has abundant lymphoid and epithelial component. Warthins has abundant lymphoid and epithelial component, if you want to remember. So this is the lymphoid follicle with a germinal center, very prominent germinal center, and the double layered epithelium, the cystic space, and the projection, papillary projection into the cystic space. Diagnosis, I told you, fine needle aspiration cytology, and for any swelling as such, swelling that is palpable in the body. It could be a lymph node, lymphadenopathy, it could be salivary swelling, or any other cyst or swelling that arises. Palpable, easy is FNAC. So fine needle aspiration cytology. So recurrence even here is about 2%. 2% recurrence. Okay. The first 2 objectives or the entire objective of this class, I told you at the end of the session or the lecture class, learner should be able to classify salivary gland tumors. Have you learned classification? I told you to take a screenshot also. So in general, they're classified as benign, malignant. So benign are adenomas, that is epithelial mesenchymal, adenomas pleomorphic, monomorphic. Under monomorphic, Warthin's tumor, oxyphil adenoma, basal cell adenoma, myoepithelioma. Then mesenchymal, we just left it. Then malignant, I told you to remember only few, that is carcinoma arising from pleomorphic adenoma or malignant mixed tumor. 3 A's I told you, adenoid cystic carcinoma, acinic cell tumor, adenocarcinoma, and squamous cell carcinoma. Then the second objective was to know the gross and microscopic appearance of adenomas, not all adenomas. Gross and microscopic features of pleomorphic adenoma, then gross and microscopic features of Warthin's tumor. Are we done with salivary tumors now? I'm sure all of you will remember even the clinical features. I've shown you a lot of pictures of patients. I've shown you gross pictures also, and several times I've repeated. So that is like memorizing. Yes. So what are the other lesions of salivary gland? There are so many other lesions of salivary gland. Common actually I should say is sialadenitis. What is sialadenitis? Itis. What does itis stand for? We've taught you in inflammation that itis means it's a suffix that is added to talk about inflammation. If lymph node is inflamed, what do we call it as? Lymphadenitis. Right? If appendix is inflamed, what do we call it as? Appendicitis. Hair follicle is inflamed, folliculitis. Pancreas is inflamed, pancreatitis. Liver, hepatitis. Gastric or stomach, gastritis. Esophagus, esophagitis. Gingiva, gingivitis. Right? So itis is the suffix we add to denote inflammation. Right. So what is sialadenitis? Sialadenitis is inflammation of the salivary glands. Have you seen inflammation of salivary glands? Any disease have you heard? So talk to your parents or grandparents and all that. You ask them if these salivary glands are enlarged. They're swollen, not enlarged. Swollen is better. Swollen, painful red in a child who has got fever, pain in this. Immediately they'll tell you that, oh, mumps. It could be mumps. Mumps is a viral infection. Okay. So sialadenitis is inflammation of the salivary gland. Acute. It could be acute or chronic. And the latter is most common. That is, the chronic form is more common. Chronic sialadenitis. So what are all the causes for sialadenitis? What causes infection? Like anywhere. It could be virus, it could be bacteria, it could be fungus, or it could be some other physical agent. So here we talk about viral infections as the most common. The most common inflammatory lesion of salivary glands, particularly parotid, is the viral infection, that is mumps, which occurs in children of school-going age. It comes as epidemics also. So recently, maybe 5-6 years back, we had this epidemic. Mumps, we get scared, especially in boys who get this, because this mumps virus causes orchitis also. That is, what is orchitis? Testicular inflammation. And people are worried that if with testicular inflammation, it may lead to testicular atrophy. That's how people are scared. So why now we don't see this quite often. Mumps. It's a preventable infection, viral infection. So how is it prevented? All of you have received a vaccine which is called as MMR. MMR vaccine. What does it stand for? Mumps, measles, rubella. And now you know with COVID, people who have received MMR vaccine, they say have, especially rubella vaccine, the antibodies which are present in the humans who have received this is having some protective effect against COVID-19. Okay, so measles, mumps, rubella, MMR vaccine, or even this is now it's a general national health policy. So national immunization policy, and all of you have received it. It was not there probably say 50 years back. Yes. So mumps occurring in school children, children of school age. Then the triad of this viral infection is, especially mumps, is epidemic parotitis. Now it's not epidemic; it's prevented now. Orchitis, oophouritis. Orchitis is testicular inflammation. Oophouritis is ovary that is inflamed. Then pancreatitis, involvement of the pancreas. This triad. This is mumps. Now, so less common cause. So viral cause for parotitis is mumps virus. Then less common is cytomegalovirus infection. Then second cause is bacterial or mycotic infections. Bacterial infections. Yes, they cause most often salivary acute sialadenitis. Sometimes there could be recurrent attacks of acute parotitis. Acute sialadenitis in acute infectious fevers, acute postoperative and general debility, old age and dehydration. Then chronic sialadenitis. So this results from recurrent or obstructive. One type is recurrent obstructive type. So why? Because of calculi. When there is a calculus or calculi in the salivary duct, that causes obstruction and infection. Then recurrent non-obstructive type. This is due to non-obstructive causes like hyposalivation. I think you've experienced when you take antihistaminic, your mouth and all that become dry. Then chronic inflammatory diseases, tuberculosis, actinomycosis. Then autoimmune diseases. I'll just tell you about two syndromes here and stop. So one is Sjogren's syndrome. So what is it characterized by? Dry eyes, triad of dry eyes. That is keratoconjunctivitis, sicca, dry mouth, xerostomia, and rheumatoid arthritis. Rheumatoid arthritis, dry eyes, dry mouth, keratoconjunctivitis, sicca, and then xerostomia and rheumatoid arthritis. Autoimmune cause for sialadenitis. Then Mikulicz syndrome, which is combined with, can you see the lacrimal glands enlarged here? Symmetrical, bilateral. Then xerostomia, the dry mouth, and enlargement of the salivary gland. So this is Mikulicz syndrome, combination of inflammatory enlargement of salivary, lacrimal gland, and xerostomia, usually bilateral. So grossly, the affected salivary gland is enlarged. In acute stage, acute inflammation, we have taught you all features would be there. In late stage, there is fibrosis. And microscopically, we see fibrosis, chronic inflammatory cells. And if there is a specific cause like tuberculosis, then we see granulomas and all that. So this is about sialadenitis, which is inflammation of the salivary gland. Okay. So now I come to the end of this session. So hope I've met with the objectives. I have done my duty as a teacher, but the rest of it lies in the student to learn. I am positive because all of you would definitely have learned it. Okay. Thank you. Take care. Take care of yourself and the community. Now we see COVID in the community spreading so fast. Wash your hands 20 seconds with, at least for 20 seconds with soap and water. Use the sanitizer. face mask. I've just removed it here. Okay, social distancing. So keep educating everybody. Stay safe. God bless you all. Please contact me for any other queries that you have regarding your learning of pathology. Thank you.